since morning, we've been discussing how to treat heart failure, how to screen for heart failure. And this is a new for me as well. And that's why I asked Rosanna first question about this. But we didn't get the answer. I don't have an answer as well. Okay, so as I said, for last 30 years, we've been looking at the mechanism of behind heart failure, and we managed to get the management, treatment for that. But despite of all shortcoming, the adherence and all that, I think we're doing a good job in terms of treatment. So, but the question is still, we have admission. Dr. Khalid bin Thani talked about that, and we're still having problem of optimizing the management of this patient. Maybe we are missing that link of something else is behind, the not only neurohormonal, is something else. It's not hemodynamic, maybe inflammation, maybe. Yeah? So how many of us do this for heart failure? I think almost everyone does, just looking for the consequence, resuscitating. But how many of us, think about this using high-sensitivity CRP? This may be the reason for this presentation, okay? So HFpEF and HFrEF. HFrEF, okay, fine. HFpEF is the area which is still, we're struggling with. I tell you, diagnosis, I think we spend from today until tomorrow, we don't know what's the diagnosis, but anyway, it's growing. The reason for that, the obesity is high, the cardiometabolic is high, hypertension is high, aging, the main reasons for us to have PEF. So, but again, I don't know the diagnosis. Okay, somebody with the symptoms of heart failure as exclusion, that's HFpEF until proven otherwise. Have that in your mind. So it's a systemic inflammation in HFpEF. So think about that and think about your patient you see every day. I think everyone got HFpEF now, if you think about it. So what should I do? We are limited with the management, and just simplify this. This is basically tells you this, that your patient you're seeing in your clinic like that, okay? Obese, diabetic, especially in our region, صح? So we already have an inflammatory patient in front of us. So it's already there. So that complex is this the answer, okay? So this is what I said. Every time I ask the expert, they talk about HFpEF. How do you diagnose? Very difficult, heterogeneous, it's a systemic disease. Ejection fraction is preserved. That's the first thing we say. What was the ejection fraction? Normal. Okay, I don't know. Could be many things. Could be this, could be that. But they say there's something called HFpEF. Today, with our expert of echo, spending on how to do the GLS, looking at, again, if you look at GLS, again, it's operator dependent. You can play with that. You can make it normal, you can minus 20, minus 80, minus 10, you can play with it. But of course, you need to use these tools to help you. There are some scores to help you as well. But so, could this patient symptom, this you ask your question, any patient come to you, symptoms of heart failure, can this be explained by HFpEF? Okay, then come the next question. What do? You start the treatment. What's the treatment? We have all the management. I show you now. So the cornerstone is, I think for diagnosis, is the most important. If you don't know the diagnosis, the management will be wrong. So underdiagnosed patient receive no treatment, صح? You don't know. Is this HFpEF? I don't know. Okay, leave it. Leave it to my colleague. Leave it to Dr. Rosano. Dr. Rosano, I don't know. I'm busy. So late diagnosis means advanced disease. Okay, earlier diagnosis allow earlier intervention. So every effective HFpEF therapy starts with recognition, and that's we're failing in every aspect in medicine because of that early recognition. And we know this. The only one is SGLT2, and so which one? Use anyone you have. Don't just disagree on that. Okay, but the 4 pillars I call it like this: early diagnosis. Again, that's the first pillar. Treat congestion, of course, and then treat the systemic, then initiate SGLT2. Then think about, after you do that, think about next. The problem is that, despite all that, imagine you've done your great job, you've managed the patient optimally, but still, patient having admission, still we have problem, patient mortality, morbidity. So, HFpEF is not simply hemodynamic disease, it's a systemic disease. So that's maybe take us to think about inflammation, interleukin 6, and HFpEF and HFrEF. These both results, just make it simple, so development of HFpEF related by interleukin 6, cardiac remodeling and fibrosis. So these are happening early, before you get the symptoms. Worse symptoms and outcomes, of course, and that will come, of course, in the future. So the remarkable thing is that inflammation appears before many years of manifestation of heart failure. I'll show you some of the cases. So look at this. Interleukin 6 is highly related with the cardiac death, CV death, subsequent HFpEF. So if a biomarkers repeatedly predicts death, okay, you see this, hospitalization and progression. So at what point you will call this, is a therapeutic target rather than just a biomarker? At what point? Of course, that means make you think. So basically, this is what I'm trying to say. That kind of patient with these parameters is HFpEF. So that's where you need to think for inflammation. So I show you HFpEF, a systemic disease with all the obesity, diabetes, hypertension. Think about inflammation. So it is associated with entire cardiometabolic syndrome. Obese, diabetic, think about it. This is exactly the patient sitting in front of you every day. I think every day I see that kind of patients. So interleukin 6 stimulate hepatic production of CRP. That's difficult to measure. And so what we have CRP. So interleukin 6 drives CRP production, CRP becomes our clinical window into inflammation. So we cannot measure every inflammatory pathway, but what we can measure is high sensitivity CRP. And you have CRP and I have high sensitivity CRP. CRP, I call it a fire. High sensitivity CRP is a smoke. Smoke, fi dukhan. So that makes you think about what's going to happen. Okay? So just to make all this, what it says here, I already said it, okay? So patient with higher CRP had significant higher risk of developing heart failure, including HFpEF. Inflammation predicts future HFpEF, years before diagnosis. Okay? And that's another way to look at it. So if HFpEF identifies a higher risk phenotype, think about it, okay? Patients with high sensitivity CRP are more symptomatic, more congested, and nearly twice as likely to experience major heart failure events and hospitalization. So that high CRP in that scenarios helps you to phenotype your patients to think about optimizing your standard, what you have, and think about what else you can do for patients. So what you can do for time being, you can reduce their weight, you can optimize their diabetes, you can make them exercise more, eat vegetables, try to optimize their whatever increase inflammation. Obesity inflammation, we'll agree to that. Hypertension inflammation, diabetes inflammation. But at the moment, we are having this, but still, despite of that, these patients are still having problem. So this is a nice study to look at what percentage of these patients who are heart failure, focusing HFrEF, HFmERF, HFpEF, whatever, all of them have inflammation in equal percentage. So 4 out of 10 of heart failure, your heart failure has got inflammation. What do you have for them to do? You have already, but we are not doing the good job. We are not focusing, we are not improving their diabetes, we are not improving their obesity, we are not improving their hypertension, which you're going to hear more about it. So this is a global study. It's not a one center, it's not the UAE or America, it's global. So that's why you have more trust in it. Okay? So that tells you 4 out of, so 38% of patients, doesn't matter which ejection fraction, patient had inflammation. And then interleukin, and you can see that's high among all the ejection fraction, regardless the NT-proBNP, which is maybe higher at certain ejection fraction. Okay? So what I'm trying to say here, that's if guidelines-directed therapy was completely eliminating inflammatory risk, would we still see almost 40% of patients with high sensitivity CRP? I don't think so, because we're using the optimized 4 pillars, and we're using the other pillars, we're using treating diabetes, obesity. If still we have that inflammation there, so that means we need something else, okay? And that's the summary of the study, Just make it even more specific. Inflammation is common among heart failure, regardless what type. And think about HFpEF, because we still have no enough tool to manage that area. Inflammation is global. Inflammation persists despite all the medication and all the medication for the inflammation you have. So if high-sensitivity CRP identifies the patient at risk and interleukin drives high-sensitivity CRP, then obvious next question is, can targeting interleukin 6 change the natural history of heart failure? This is what is coming. Okay, this is the monoclonal antibody is coming. There are two studies. Okay, I will not go through this. There are two studies. One is called Hermes, which is, does targeting inflammation reduce events, so outcome? And Athena, does targeting inflammation improve symptoms, in fact, which is quality of life? You know, despite all we do, there are still people dying. There is a morbidity. So if we can answer this, then hopefully Dr. Rosano and the people will be out of business. Anyway, so that was a study. Take-home message. HFpEF is increasingly inflammatory cardiometabolic disease. We agree to that, huh? HFpEF. We're not talking HFpEF. 4 out of 10 patients have residual inflammatory risk despite optimal therapy. We saw that. High-sensitivity CRP identifies higher risk heart failure phenotype. Yes? Because you've done your job, but still these people having that. So this one you want to focus for future or optimize whatever you have at the moment. Inflammation travels with obesity, diabetes, CKD, hypertension, and AF. Current therapy help, but do not eliminate inflammatory risk. We know that. These two studies hopefully will answer our questions. So I finished 8 minutes early.
Thank you.